Once again, welcome to the teaching session of Department of Urology, Savai Man Singh Medical College, Jaipur. So today we have a class on oligometastatic prostate cancer. It will be presented by Dr. Sudeep Singh, our resident, and would be moderated by our faculty, Dr. Jangid. So I welcome you all. And Dr. Dharmender, please ask the presenter to start the presentation. Yes.
Hello. Good morning, respected teachers and my dearest colleagues. Today we're going to have a discussion on oligometastatic prostate cancer. So what is oligometastatic prostate cancer? It is an intermediate or a transitional disease state, and it is characterized by limited metastasis. And there is a spectrum theory that it ranges from an indolent to a widespread metastasis. And even the Halsted stepwise and the Fisher systemic pattern of metastasis also included in the oligometastatic prostate cancer, which were originally described for breast cancer. So why does it matter? It is an intermediate state and a limited metastatic state. And it implies that we have a window of opportunity in which local treatment, that is primary with oligometastatic site treatment, and it can impact the outcome of the disease. This is well established in colon cancer, in which if a patient has colon cancer and he may have a single hepatic lesion, metastatic lesion, that can be taken care of with metastatectomy. So there are various potential pathways of metastasis. The primary tumor first enters the oligometastatic phase, and it may, in an indolent fashion, progress into a polymetastatic phase, or it may just stay in the oligometastatic phase for longer time, or it may progress. There may be a rapid progression to a polymetastatic phase, in which oligometastasis was just an transient state. So the natural history of oligometastatic prostate cancer includes the patient may have a primary localized tumor, which we may cure with the intent of a cure, and later it may progress into a oligometastatic state and further to a polymetastatic phase. This is the biological model, which hypothesizes that it represents a stage in which the tumor lacks the necessary hallmarks of the cancer to metastasize to specific sites. So in systemic disease, the cells are actively migrating cancer cells into hospitable targets. But in oligometastatic disease, only the sloughed off cancer cells, they may go into inhospitable targets and which may not progress further. There are various definitions of oligometastasis. There's no clear-cut definition of oligometastasis. As per different trials, there have been different definitions. So it includes the site of disease, that is only bone or any other site, bone, node, or soft tissue. The number of lesions, in general, it is 1 to 5. The temporality of the disease, whether it is synchronous or metachronous or progressive. And the castration status also is included. Like hormone sensitive, it is the most common, and castrate resistant. So these are the various published literature we have in the data we have on the definition of the oligometastatic prostate cancer, in which we can see in 2004 study, they used a cutoff of less than 5 oligometastatic lesions in any location. And in 2018, they reduced it to less than 3 in any, and the imaging modality has been changing from time to time. These are also a few trials, with one of the latest trials in which have defined the low volume or the oligometastatic prostate cancer. The HORRAD trial, it defines less than 5 bony lesions, and it was assessed by bone scan. And in the STAMPEDE trial, less than 4 lesions with no bone lesion beyond the vertebral body, or no visceral mets were included. And this was assessed by bone scan, CT, or an MRI. And the STORM trial in 2017, it included less than 4 extracranial metastasis. So, and it was assessed by choline PET CT. So there are 3 entities of oligometastatic prostate cancer. Oligorecurrent prostate cancer, it occurs if the primary has been treated. We have given primary localized therapy to the prostate, and after that, a metastatic lesion has been seen. This is done whether after radical prostatectomy or after radiotherapy. Then comes the de novo oligometastatic prostate cancer, in which there has been spread before any definitive therapy to the primary tumor. And in this entity, the primary tumor would need to be managed in addition to the distant metastasis. Then comes the progressive prostate cancer. It is defined as a widespread metastasis with only a few sites of progression on systemic therapy, and it probably harboring the worst prognosis out of the three entities. The genomics include, there are polyclonal prostate cancer tumors associated with a higher risk. The miRNA 200C enhancement is seen in oligometastatic cells, and non-linear clonal evolution in metastatic site, defined as clones from the metastatic sites being able to see to other sites. It has been shown in prostate cancer. There are various investigations to diagnose oligometastatic disease. The current practice includes conventional imaging modalities to define the extent of metastatic disease. It includes CT scan and bone scans. And then later came the PET scan, in which various radio tracers are being used to enhance the identification of occult or the hidden metastatic disease, and it has increased the incidence of oligometastatic and polymetastatic disease. The various radio tracers being used right now are choline, flucyclovine, PSMA, that is prostate-specific membrane antigen, 18-FDG, and sodium fluoride. MRI may play a role in some appropriate patients in which we are considering aggressive multimodal therapy. But there are few limitations of MRI, like the resource, and it is a time-consuming protocol. There may be artifacts in the MRI. It's a very high-cost investigation, and there is inter-reader variation in this. So this image shows a gallium PSMA PET scan in a patient with oligometastatic prostate cancer, and in which there is a solitary lesion seen in L5 vertebral body, in patient who has been treated with radical prostatectomy. The various treatment modalities available in oligometastatic prostate cancer. First comes the local treatment of the prostate. So we all know that the primary tumor in prostate cancer plays a substantial role in the disease progression, even after and despite development of metastatic disease. So the rationale behind the local treatment is that we have to reduce the tumor burden. So currently, radiotherapy is being combined with androgen deprivation therapy, and it has been shown to have a synergistic effect, which results in double-strand DNA break in cancer cells and further resulting in apoptosis. And there is a documented immunomodulatory effect of this combination also. This enables a subset of patients to delay or interrupt the systemic therapy, decreasing the subsequent adverse effects of the systemic therapy, and improves the patient's quality of life. So coming to the androgen deprivation therapy, which is currently the standard of care, we all know that prostate cancer is driven by testosterone. So we have to reduce the testosterone levels in the body to decrease the cancer's growth and to shrink the cancer temporarily. Castration level, we all know, is when the testosterone level is less than 50 nanogram per deciliter. So there may be medical therapy or there may be surgical castration, that is bilateral ocheectomy, or we may give it intermittent or continuous. And few studies have shown that intermittent androgen deprivation therapy is proposed to reduce the adverse effects on the poor quality of life associated with continuous ADT. The quality of life is in favor of intermittent ADT compared to continuous ADT. And in the current era of early systemic therapy for hormone-sensitive disease, intermittent ADT is likely to be suited in patients with low volume disease or low volume M1 disease. So this is the brief table describing the medical therapy. First, there is the gonadotropic releasing hormone agonist like leuprolide, which acts on the anterior pituitary gland and it decreases the release of LH. And then comes the GnRH antagonist like aberalex, which also acts on the anterior pituitary gland, and it directly inhibits the GnRH receptors. Then we have the adrenal ablating drugs like ketoconazole, which acts on the adrenal gland, which decreases the androgen synthesis from the adrenal. Then comes the androgen receptor antagonist like flutamide, bicalutamide, and nilutamide, which acts directly on the prostate gland, and it inhibits the androgen receptor ligand binding domain through competitive mechanism. And lastly, we have 5-alpha reductase inhibitors like finasteride, which acts on the prostate, which decreases the conversion of testosterone to dihydrotestosterone. But this has not shown any defined role in standard care of prostate cancer. So this is a suggested algorithm in patients with advanced prostate cancer who are suitable for either intermittent or continuous ADT. So if we have a rising PSA level and the patient is hormone sensitive, he may be non-metastatic or metastatic. In case the patient develops the side effects of ADT and if the Gleason score is less than 8, or if even it is more, we may consider the patient for intermittent ADT. If there are no symptoms due to ADT, we may go for continuous androgen deprivation. And in case the patient, we have to see the symptoms due to the ADT risk stratified based on the PSA levels. If it is poor, we have to go for continuous androgen deprivation. If it is a good or intermediate, we may counsel the patient for intermittent ADT. So these are various side effects of ADT: fatigue, loss of libido, hot flushes, osteoporosis, and some metabolic effects like body appetite change. The lipid profile may derange. There may be insulin resistance and type 2 diabetes mellitus and metabolic syndrome and other cardiovascular comorbidities. Radical prostatectomy and oligometastatic disease. So there have been retrospective studies which have shown that there is improvement in several distinct outcomes. It delays the castration-resistant prostate cancer and decreases the development of bony metastasis and the progression-free survival and overall survival. But there is no published prospective trial or study at present in regards of radical prostatectomy for oligometastatic disease. Radiotherapy, it is the backbone of oligometastatic disease treatment. There have been retrospective analysis of large cancer database which suggests that there is benefit of radiotherapy to the primary tumor in metastatic hormone-sensitive prostate cancer. So there are various modalities of radiotherapy, and it has an important role, and it ranges from upfront treatment of localized disease with a curative intent to post-radical prostatectomy, adjuvant or salvage settings, or it may even be given in case of palliation in men with symptomatic metastasis. And clinical studies on radiotherapy used in oligometastatic prostate cancer have focused on both external beam radiotherapy and stereotactic body radiation therapy. The mechanism of stereotactic body radiation therapy, or SBRT, is distinct from EBRT. SBRT, it precisely targets the lesion with the intensified radiation dose while minimizing the radiation exposure to the adjacent normal tissue. And compared to EBRT, which delivers the localized cytotoxic effects, SBRT is shown to induce immune response with potential for additional tumor control. So there was a HORRAD trial, which was it was a multicentric randomized control trial for oligometastatic prostate cancer, and they assigned it to external beam radiotherapy to patients with ADT or ADT alone. And this is the only negative trial which has shown that there is no benefit of adding radiotherapy. And the outcomes were comparable in both the groups. Then came the STAMPEDE trial. It is still an ongoing multicentric, multi-arm randomized control trial in Europe, and it has enrolled more than 2,000 patients right now. And they have been randomized the patients to either standard of care ADT with or without docetaxel versus standard of care with radiotherapy. And this trial has been shown to improve that there is a failure-free survival in patients with radiotherapy compared to the standard of care alone. And it has improved the 3-year overall survival in low burden disease. Then came the POPSTAR trial. It is a single arm prospective trial. It has been assessing the safety and the feasibility of SBRT in metastatic sites. And it has shown that the local progression-free survival and the distant progression-free survival was 97% and 58% respectively. And it was less in patients who were only on ADT. And in those patients in whom androgen deprivation therapy was not given, the 2-year freedom from ADT was 48%. But there was no significant difference in baseline quality of life. So on conclusion, they made that this single SABR session, it was feasible and associated with low morbidity in this cohort. Then came the STOPCAP meta-analysis. This is a meta-analysis which has rounded up all the various trials like HORRAD, STAMPEDE, and the ongoing PEACE-1 trial. And it has shown that there is an absolute improvement in 7% in 3-year survival in men with lower, less than 4 or fewer bony metastasis. And there is improvement in the 3-year biochemical progression and the survival by approximately 10% in unselected men, but the side effect has varied by metastatic burden. Then latestly, we have the metastasis-directed therapy. The rationale behind this is that primary tumor seems to be responsible for the expression of the signaling pathway, which activates the epithelial mesenchymal transition, and it facilitates the release of tumor cells into systemic circulation, and it initiates the metastatic process. And there is production of necessary chemokines and angiogenic factors, fibronectin, and infiltrate cells, and other hormonal factors. The primary tumor appears to play a role in development and maintenance of these metastases. And notably, the new metastatic foci, they also act as a source of additional metastasis while maintaining communication with the primary tumor. And it releases the tumor cells into systemic circulation. So combined local therapy to the primary tumor and metastatic-directed therapy in de novo oligometastatic setting is being given. So we have been using SBRT, which is defined as a high-dose radiotherapy given in few fractions directed at extracranial sites. The small retrospective reports, they have shown to improve the progression-free survival and the overall survival in recurrent or de novo oligometastatic settings. The metastatic directed therapy with radiotherapy can provide local control, and the toxicities are minor. So this is a summary of other studies using radiation therapy as a metastatic directed therapy from 2007 till 2013, in which different modalities were used like external beam radiotherapy and SBRT. And there has been we have seen overall survival to be from 70% to 100% at 1 year after giving this therapy. So then came the STORM trial. STORM trial, it was a trial for asymptomatic oligometastatic hormone-sensitive prostate cancer. In patients, they were randomized to either surveillance or metastatic directed therapy for all the detected lesions, which may be done by surgery or SBRT. And in the median follow-up, the ADT-free survival was 21 months in the metastatic directed therapy arm, compared to 13 months in patients who in the other group. But there's no statistically significant improvement in 1 year quality of life as per this trial. So ongoing latest trials. So the most current anticipated trial is the randomized phase 3 protocol. It is based by the Southwest Oncology Group, and it plans to enroll 1,273 patients with de novo oligometastatic and non-oligometastatic disease who are assigned to receive either standard systemic therapy or standard therapy plus radical prostatectomy or radiotherapy to the prostate. And it is the largest trial in this unique space, and it will allow all the patients with oligometastatic disease to receive metastatic disease therapy, directed therapy to less than in patients with less than 4 sites before randomization. So then then the ORIOLE trial was published in 2020, and it was between observation versus SBRT for oligometastatic prostate cancer, and it denoted that the SABR, it improved the median progression-free survival. Then came the TROMbone trial. It checked the feasibility and the safety of radical prostatectomy for oligometastatic cancer, and the quality of data shows that there is similarly high functioning in both the study arm. And surgery for men with oligometastatic prostate cancer was found to be safe and had similar impact on early functional outcomes as surgery for standard indication. And the surgery appeared to be safe with no substantial impact on quality of life. So the latest, we have a BULLSEYE trial. It uses lutetium-177 PSMA INT as a metastasis-directed therapy in oligometastatic hormone-sensitive prostate cancer. So there are many patients who do not qualify for external beam radiotherapy or targeted therapy before due to prior some interventions or the tumor location. Such patients may benefit from radioligand therapy with lutetium-177 PSMA, which has been used as a novel tumor targeting therapy for end-stage metastatic castrate-resistant prostate cancer. So the currently favored PET tracers are gallium 18F and PSMA ligands. And gallium PSMA PET has excellent sensitivity and specificity to detect prostate cancer. And they may be labeled with beta emitters like lutetium for radioligand therapy to deliver high quality radiation dose to the tumors directly and the same setting. So it is a beta radiation emitter with maximum energy of 0.5 MeV with maximum penetration depth of 2 mm and a 6.7 days half-life. So radioligand therapy could be more effective in low volume disease like oligometastatic disease due to high uptake of these ligands in small lesions, and it has a favorable toxicity profile. So this BULLSEYE trial, which is still ongoing, it aims to test the hypothesis that lutetium is effective treatment in oligometastatic hormone-sensitive prostate cancer to prolong the progression-free survival and postpone the need of androgen deprivation therapy. And the second primary objective is to see the time to disease progression. And 58 patients with oligometastatic hormone-sensitive prostate cancer and high PSMA uptake on 18F PSMA PET prior to surgery and or EBRT, and the PSA doubling time of less than 6 months will be randomized in 1:1 ratio. So the take-home message for today is that oligometastatic clinical state has been posed as an intermediary step along the natural history of the cancer with fewer metastatic lesions identified on imaging, which may be amenable to metastatic directed therapy. And there is effective therapy is anticipated to impact the cancer evolution by delaying its progression and improving the outcome at a minimal or acceptable cost of toxicity. And increasing recognition of oligometastatic disease in prostate cancer with the advent of newer generation imaging agents like PET scan, radio tracer based, or targeting the PSMA. So early clinical trials with metastatic therapy for oligometastasis, it has provided evidence for delaying the employment of systemic therapy and improves the outcome in selected patients. But despite these encouraging results, it needs to be investigated further. And we have to learn about the underlying biology of the oligometastatic state along the evolutionary clinical course. And we have to identify the relevant imaging and non-imaging predictive and prognostic biomarkers and further develop the treatment strategies to optimize short-term and long-term patient outcome. Thank you.
Unshare. Hello. Nimeshi, has anybody joined from outside?
Yeah, hi, Shivam. Can you hear me?
Yes, I can hear you.
Aditya
Dr. Rawal, please. Yes.
Aditya Pradhan.
Oh, okay. Dr. Aditya Pradhan. Great, great. Welcome to our teaching class.
Thank you. Very nice.
Yes, please go ahead.
So I was listening to this presentation. Very good.
Yeah.
Factually, the what the contents is given, yes, but the line of thought which was there in this treatment is slightly been diluted. So I'll just put 1 or 2 points for the consideration. See, when we talk oligometastatic, it's not only treating the metastatic site. So when you see a patient of oligometastatic, your considerations are actually based on 2 or 3 parameters. The first parameter is that has the primary site been treated, which means have you done a prostate surgery earlier, or have you done ablative radiotherapy earlier, and therefore this is a treated primary, and then he has got oligometastatic disease, which means by definition oligorecurrent. So here is the situation. Primary has been treated. There are few sites of metastasis. He is not on systemic therapy, and now you have to decide your plan of action. So this is the first clinical scenario. The second clinical scenario is where the patient has come with de novo mets to you, which is the standard oligometastatic disease status. Here, your considerations are twofold. First, how do I treat the primary? Second, do I treat primary only, or I include the nodes? And the third is, do I treat both? So this is consideration number 2. The third scenario is where you have actually a patient pre-treated systemically. So he has had a good response all over the body, but he starts showing a PSA progression, and that's only on your imaging showing up in 2 or 3 sites. The rest is all quiescent disease. So you need to actually define your aims of treatment in a MDT team, and then take a call on how you have to do it. Like this was brought out, there are some trials. Yes, there are trials. But what is the aim of the trial? Those trials are small, they are prospective, and therefore they are the only ones giving you currently data on this. As of today, the EAU, ASTRO, and the American guidelines all are only saying standard of care is radiation, because the one trial which he was mentioning, that's a short retrospective study. It is not accepted as level 1 evidence. So today, clinical status for cytoreductive prostatectomy, as it is called, is not accepted as standard of care. We will have the data in a few years, but this is where we stand today.
Yes, Aditya, thank you. Thank you for your comments. Can you hear me?
I can go ahead, please.
Yes, yes. So he had a slide in which he showed, yes, where the points that you made. One is oligometastatic could be 3 types. One is when there is an oligorecurrent prostate cancer. That means the primary tumor has been treated, and then there was a recurrence. And the second is the de novo oligometastatic, when the patient comes with the oligometastatic prostate cancer scenario. And the third one is when the oligometastasis progresses. Right. So these 3 scenarios were probably discussed, and you made those points very correctly, that the treatment would differ and the prognosis would also differ in the 3 scenarios. Right. And anything else you would like to say?
Yeah, see, what I was trying to say is today we don't have any evidence which is what is better. As a surgeon, we would default on trying to treat the primary as to the extent possible. So here is the question of how do you decide operability? There's no real guideline to tell you, yes, this is operable and this is not operable. It depends on his profile, how is his performance status, what has been his comorbidities, and whether the disease is very extensive at the apical area, which is definitely likely to make him incontinent with your surgery. So these are some of the considerations when you say yes or no to surgery. The second point is, why is surgery being increasingly proposed as a better treatment, is that you have treated what all can be potentially a problem for him. Because in this short window, if he's treated by surgery, then the future problems like needing, when he becomes CRPC or so, he will require catheter, he'll require SPC, he'll require stents. So all this is bound to happen in the natural course of disease. So it is very favorable in patient care to allow the primary treatment to be done first and get rid of these potential problems later.
Right. You are very right in saying that, yes, as aggressive as you go, the chance of developing complications would also be higher, and you do not know whether you are actually benefiting the patients or not benefiting the patients. There are no guidelines as such today for treating oligometastatic prostate cancer, but definitely there are various trials, and the studies probably have shown a little survival benefit in giving a kind of a multimodal therapy to this particular kind of scenario where there is de novo oligometastatic prostate cancer. So yes, the time will tell exactly whether we are going in the right direction or not. But definitely we need to research more on this particular kind of setting. to help our patients. As in other cancers like RCC and etc., the paradigm is now shifting towards more aggressive therapy in advanced prostate cancer also. And this oligometastatic prostate cancer term was given by Hellman way back in 1995. And then since then, we had so many trials of regarding this particular scenario. And actually, what the basic idea probably is that in such a setting, probably the treatment can bring a deep remission or a near cure kind of a thing. So basically, it will consist of three kind of treatments. One is a local consolidated therapy, which not only includes a radical prostatectomy, as Dr. Aditya says, a radical prostatectomy may not be a correct approach in every patient of this advanced prostate cancer. Then we have radiotherapy, either brachytherapy or a combined brachy and EBRT for local consolidative therapy. And then there is a metastasis-directed therapy where we either give SBRT, as you said, stereotactic body radiotherapy, or we can, even if there is one or two metastases, we can excise that metastatic site also. So metastatectomy. And the third is systemic therapy, because we know this locally advanced will have some kind of micrometastasis. So giving a systemic chemohormonal therapy in a very aggressive approach might help this patient. So all the three together. So usually there was a trial called METACURE trial where they studied first with aggressive systemic therapy in the form of chemohormonal therapy, followed by radical prostatectomy or by brachytherapy or EBRT, and then followed by stereotactic radiotherapy for metastasis. So all these three together can probably help some of these patients and may increase the survival of these patients. So definitely there have been a change with the molecular imaging that we have come up with PSMA PET-CT, which will exactly tell you that which are the sites and what are the number of metastatic sites involved, which has helped in definitely the treatment approach. And then we have that genomic data also, which also tells you that there is a biological difference between oligometastatic prostate cancer and a widespread metastatic prostate cancer. So these things, ideas might suggest that yes, the treatment approach to de novo oligometastatic prostate cancer could be trimodal therapy also. So thank you very much. If anybody has any query, resident or faculty, Dr. Nachiket, you want to say something? And from the Zoom, if anybody has joined and wants to ask anything or clarify anything, please go ahead. Yes.
So Sir, I think that the only thing that I want to say about oligometastatic disease is still that there is no definition presently that is accepted by all the faculties which are treating metastatic prostate cancer, and I think that everybody is still searching for the exact definition of oligometastatic disease. When it came in a big way 15 years back, I remember then oligometastatic used to be strictly considered to be lymph node metastasis, which is still inside the pelvis, less than 3. Then for a matter of convenience for the radiation oncologists, they said that no, even if it is outside the pelvis, inside non-draining lymph nodes, inside the retroperitoneum, still there are 3. Then we are going to consider it oligometastatic. Then again, the radiation oncologist said that, okay, oligometastatic is something, if there are 3 inside the bones, but it has to be non-visceral. Then when chemotherapy started coming, like docetaxel started giving good results and paclitaxel started giving results, then they included, even in the STAMPEDE trial, visceral mets, but they had to be less than 3, then the number became 5, then the number became 7. So whatever is suiting everybody's, I think, treatment modality, people tend to, push that treatment modality for oligometastatic disease. For example, if the radiation oncologist says that, okay, we want to give primary radiotherapy to the prostate, then they will push also stereotactic radiotherapy to the oligometastatic sites. The oncologists now, they are pushing docetaxel in oligometastatic disease because the radiation oncologists themselves, they want to promote chemotherapy. So the surgeons, they say that, no, we want to do, as it's a low volume disease, we want to resect the primary. We also want to resect the limited secondary, be it now also inside visceral mets. If it's a small liver, we want to take out a part of the liver. So the problem is that the number of trials are very limited, and there are too many trials, too many modalities which are treating this. So I still think that as a urologist, if there is oligometastatic disease, then still we have to treat the prostate as the primary, and we should not get swayed by limited trials with limited cooked up knowledge. And I still think that if it's visceral, then we should maybe start with chemotherapy. Personally, this seems to be a good option, and maybe hormonal therapy or radiation if it is limited bone mets. But the thing is that there is no set criteria for this. Is the only thing that I want to add, sir. Actually.
Thank you, Nachiket, for those comments, because yes, as in any other cancer treatment, there are a lot of things, that treatments that are coming up may be market driven also. So we, as the clinicians, we have to be very, very kind of judgmental in that. We have to see whether this treatment will actually suit the patient or not. So definitely well taken, your comments. And as yes.
One small...
Aditya, please go ahead. Please go ahead.
Yeah, one small comment on what Nachiket just said.
Yeah.
STAMPEDE trial, he mentioned, it's STAMPEDE H arm, okay? And even the ESMO guideline now, which has been given as a review article, visceral is not included in the definition. Then the reasons are very clearly spelled out. When you try to do such interventions in visceral, you don't have as good a result. So currently visceral is not accepted in that. So even in there are two trials which were actually used when the EAU accepted it as a standard of care. One is the STAMPEDE H arm, and the second is the HORRAD trial. But all the other trials also have mentioned that visceral is not included when you consider a disease as oligometastatic. Bone and lymph nodes only.
Yeah, Aditya rightly said. Yes, most of us would agree that this will include the extrapelvic metastasis, which are non-visceral. And most of the trials have 5 or less than 5 taken as oligometastatic prostate cancer. Though some have considered 4 or even 3, but 5 or less than 5 probably is agreed by.
Radiation oncology even
7 also. So, but on an average, we would consider it as 5 or less than 5, and which are extrapelvic and non-visceral bone metastasis, which would probably require a more aggressive approach, can help some of these patients. So thank you, Dr. Aditya, for joining us. It was a real surprise to us, and welcome. We were all pleasantly surprised. Thank you. And if anybody else has anything to say, otherwise we will wind up the session. Okay, Aditya, last comment.
It was, thank you. It was a nice topic which I just saw when I was looking through my messages, and therefore I was tempted to join in. Thanks a lot.
No, thank you, Aditya. Thank you. So thanks, everybody. Thanks all the residents, faculty, and all those who might have joined us today on Zoom and YouTube. Thank you.